Friends, colleagues, ladies and gentlemen, I bring you warm greetings from Singapore. I'd like to thank the organizing committee for a kind invitation to speak. My topic is on the latest updates in the management of metastatic hormone-sensitive prostate cancer patients. These are my conflict of interest disclosures as well as some disclaimers. Now, we know that there are many advances in the last decade of mHSPC systemic treatment, starting with charted trials showing chemo plus ADT showing overall survival benefit, followed by hormonal doublets, and then more recently, in the last 2 years, triplet therapy. The traditional management of metastatic prostate cancer comprises castration and waiting for mCRPC. However, in the recent trials such as Stampede control arm shows that really the median time to mCRPC could be as little as 11.2 months, which is under 1 year. And this clearly suggests that ADT alone is not going to be enough. An example is in a Titan trial of mCSPC patients randomized to ADT plus apalutamide versus ADT alone. In the ADT arm, the median time to castrate resistance was 11.4 months. Patients live about 4+ years, and they spend most of their life in castrate-resistant state. This is not ideal. Comparatively, the apalutamide arm, at a median of 44 months, still did not reach castrate resistance, and all of them and they had better overall survival. So the current decade is really an era of treatment intensification. This is a heavy slide of all the landmark trials, but not meant as a head-to-head comparison. They showed utility of docetaxel in the charted Stampede trial, as well as abiraterone for high-risk patients in Latitude trial and Stampede for all comers. Enzalutamide and apalutamide utility was shown in the Arches, Enzamet, and Titan trials. And all of them showed overall survival benefit versus ADT alone with very similar hazard ratios, as you can see here. Now we ask the question, is ADT alone enough for low volume mHSPC? Well, in the Stampede phase 3 trial, it was shown that low dose radiation to the prostate did confer an overall survival benefit in addition to ADT for low volume metastatic burden patients, not in high metastatic burden patients. And the secondary analysis showed that the charted definition did help to stratify who would benefit, in that the patients with 3 or less bone metastases or non-regional lymph node metastases only benefited from radiation to the prostate, but those with high volume or visceral metastases did not benefit. The median OS benefit was about 3.6 months. Comparatively, in the Stampede trial, we also had patients, all comers, who had ADT plus abiraterone, where the overall population OS benefit was more profound at 16.8 months. So in current guidelines such as NCCN and EAU, the use of the hormonal agents docetaxel and EBRT for low volume disease has been listed as strong evidence rating and our standard of care. However, they do not really specify guidance on choice of treatment by metastatic volume except for radiation to the prostate. If we look at the AR agents of all the trials side by side, you can see that when stratified by high versus low volume based on the charted definition, all patients really did benefit from the hormonal agents. In terms of metachronous versus de novo, there were very few in the metachronous category to sub-stratify. So how do we select systemic treatment for mHSPC? Based on the long-term survival analysis of the charted trial, you could see that docetaxel really did not confer OS benefit to low volume disease. And for the AR agents, based on all the trials we've shown earlier, the OS benefits seem to provide for all patients which are unselected except those who had chemo prior or concurrent. So when treating mHSPC patients with AR agents, the volume of disease may not matter because all are likely to benefit. Between the 3 agents, how do we select novel hormonal therapies? Again, this is not head-to-head comparison, but there's no high-level evidence for the comparison. But if you look at safety, the grade 3 to 4 AEs are slightly higher in the treatment arm compared to ADT alone, although apalutamide in the Titan trial seems to have slightly lesser difference in percentage, but this is not a high-level evidence comparison. In terms of treatment discontinuation and death due to AEs, the percentages are relatively small in comparison with ADT for all the trials. So the choice of agent really depends on a number of factors, such as patient comorbidities. For example, poorly controlled DM hypertension with liver impairment may not be so good for abiraterone. And those with baseline fatigue or history of seizures or preponderance to falls may not benefit so much from enzalutamide or apalutamide. Drug-drug interaction is important. Anticoagulants is an important factor for enza and APA, while abiraterone has concerns with antiarrhythmics. Abiraterone patients need frequent monitoring, so compliance is a factor in deciding the choice. And certainly patient preference, cost, and access are also considerations. More recently, there's been updates on certain trials using PSA response as prognostic marker. In the Latitude trial, those who achieve undetectable PSA at 6 months have a better OS after receiving abiraterone compared to those who did not achieve PSA low nadir. Similarly, in the Titan trial, those who achieved undetectable PSA also did better in terms of OS compared to those who didn't achieve undetectable PSA on apalutamide. So this study tried to compare whether there are differences in efficacy between the hormonal agents such as APA and ENZA. It was a retrospective longitudinal propensity score weighted study of 69 sites in the US of mHSPC patients who were treated with APA or ENZA. 351 patients were followed up with a similar PSA testing frequency. By 6 months and beyond, significantly more apalutamide patients attained a PSA decline of more than 90% response compared to enzalutamide patients. And PSA 90 response was attained significantly earlier in patients who received APA compared to ENZA. Of course, this is not high-level evidence, but it's some suggestion based on PSA response. Now, we also know, based on the recent triplet studies, that ADT plus docetaxel is not going to be enough. Why? We see in Peace 1, which was a phase 3 trial of mCSPC de novo metastases patients, were randomized to SOC, which was ADT, and later on ADT plus docetaxel, with or without abiraterone plus radiation therapy, or ABI plus radiation therapy. Majority of patients were of high volume disease based on the charted definition. And if you look at the overall population and those who receive ADT plus docetaxel, the addition of abiraterone conferred overall survival benefit compared to SOC alone with a hazard ratio of 0.75. And if you look at the in the Peace 1 trial, they used PSA response as a prognostic marker, whether in the overall population or in the ADT plus docetaxel population. Those who had PSA undetectable with treatment actually did better in terms of overall survival compared to those who did not, whether they added abiraterone or not. In terms of side effects, the increase in toxicity was because of the addition of abiraterone, a slight increase in hypertension and liver toxicity. The chemotherapy neutropenic effect was similar because both arms did receive chemotherapy as well. This year at the ASCO GU, the ARISON study was presented, which was a global randomized double-blind phase 3 trial. mHSPC patients randomized to docetaxel times 6 cycles plus darolutamide 600 milligram twice daily plus ADT versus docetaxel times 6 plus placebo and ADT. In the primary endpoint, darolutamide conferred an overall survival benefit of 32.5% over the control with a hazard ratio of 0.68. In the key secondary endpoints like time to CRPC or pain progression, darolutamide triplet therapy also improved compared to the ADT plus docetaxel. If you look at this chart, you can see that the addition of darolutamide really add very little toxicity in terms of all grades compared to the control. And in terms of adverse events of grade 3 and 4 and above, it was really largely similar between the two groups as well. So in a recent APCCC voting in a meeting, experts were asked to vote in which chemo-fit patients with mHSPC do you recommend the triplet therapy. For synchronous high-volume disease, 70% of experts voted to use this triplet. and metachronous, 58% voted for high volume disease only. Somewhere between 26 to 37% of experts do not recommend this triplet therapy routinely. So we now have the doublet of comprising chemo and novel hormonal agents versus the triplet therapy, which was concomitant chemo and novel hormonal agents. Now, some of the doublet, such as Arches and Titan, did have sequential or prior chemotherapy in a small percentage, but enzalutamide was unique. Enzamet was unique in the sense they had 16% sequential chemo and 45% concomitant chemo. Now, then we ask ourselves, between the triplet versus the doublet that uses novel hormonal agent, is there any OS difference? There's no high-level evidence available, but you can see if you put side to side these trials, not meant to be head-to-head comparison, it appears that compared to control, the treatment arm has very similar hazard ratios. And also the question is, in a Titan trial, does prior chemotherapy add to the efficacy and affect the safety of apalutamide plus ADT? In conclusion, looking at all the forest plots, you could see that the prior use of chemotherapy in mHSPC patients did not improve OS or any other endpoints, including deep PSA response following apalutamide plus ADT. Now, this was a presentation at the ASCO GU this year that compared side-to-side Titan versus Arisens. The author suggested that the populations from these two trials were comparable in terms of mixed all-comers mHSPC with equivalent number of de novo versus metachronous metastases ratio. Most patients were of high volume disease based on the charted definition. The median follow-up was also similar, and the OS difference between treatment versus the control was also very similar in the two trials. What's different is that there was more toxicity with the treatment therapy because of chemotherapy side effects like neutropenia, and also in the Titan trial, apalutamide and ADT maintained quality of life, which was not reported in the Arisens trial yet. The Enzamet group also presented their updated OS with enzalutamide in mHSPC patients, where they showed that the addition of chemotherapy did have some difference or advantage in the synchronous high volume disease at the beginning, but later the difference did not really pan out. So in their conclusion, they suggested that while enzalutamide continued to benefit patients in terms of overall survival for mHSPC patients, but the value of adding chemotherapy is still not clear. In this meta-analysis in the same ASCO meeting, that there was an indirect comparison with the triplet therapies versus the trials with the doublet novel hormonal agents. And the summary of this busy slide is that the significant rPFS improvement and OS improvement was observed with triplet when they compared to chemo plus docetaxel plus ADT, but not when they compared with novel hormonal agents plus ADT. So the conclusion was the addition of docetaxel triplet therapy may not delay progression or prolong survival compared to novel hormonal therapy-based doublets. So in summary, the management landscape of mHSPC is still rapidly evolving. Treatment intensification is key in improving survival. The combination therapy of ADT plus docetaxel or novel AR agents or radiation to the prostate only for low volume disease has replaced ADT alone as standard of care for mHSPC. ADT plus docetaxel is not enough. Adding novel AR agents in mHSPC patients receiving ADT plus docetaxel resulted in significantly longer OS compared to ADT plus docetaxel. Now, for patients with mHSPC on ADT plus novel AR agents, it is still uncertain who will benefit from adding docetaxel. So with that, I thank you for your very kind attention.